this is a very timely topic and discussion, so thank you. I'm going to start with the ones that got the most thumbs up. So I was give you a little bit of a break. Dr. Bello, get some water. But it's another 3. So how can, I think this is for Dr. Bello, how can non-geneticists incorporate genetics in their everyday dental public health work? And second part is, how can the dental public health workforce effectively apply genetics research?
Yeah, I think that's a great question. I think that there's a few hurdles that we have to get over before we're necessarily in a place where genomics can impact everyday care. It's important to remember that that it's not the only avenue to having genetically informed medicine to have your particular patient genotyped, right? But if geneticists identify a risk variant that gives us information about a particular pathway that increases susceptibility, pharmaceutical companies can pick up that information and can be developing and utilizing those drug targets so that we can potentially be able to apply the genomic information in a patient treatment setting without necessarily genotyping every patient. So genomics can inform our healthcare without the dentist being also a genetic counselor. I think that's an important thing for us to realize. I think we're moving very rapidly towards a health framework where more or less everyone is going to have their genomics assessed. And so probably in the next 25 years, that answer is going to change significantly. And all of us in the health professions are going to have to become more and more literate as geneticists as well. But for the immediate future, I think that we rely on the geneticists and what we can learn about the etiology of disease to help inform the care. I don't know, do you have any? Yeah.
Okay, great, thank you. I'll go with the next question. We know that implementation science is a challenge in public health. So, what are ways that we can expedite the genetic research implications to applied dental public health settings?
Well, one of the exciting directions in electronic medical record arena is implementing a comprehensive genetic-driven clinical decision support. It's particularly prominent right now in pharmacogenetics. However, with acquiring more and more evidence and data, there is ongoing effort to integrate our knowledge about genetic information directly at the point of care using clinical decision support. There's a eMERGE consortium which is particularly involved in this effort and has very prominent results. So we expect eventually that even without deep underlying knowledge of genetics, clinicians in routine care would be advised about genetically important issues and guided how to address it in their care.
Okay, so so the next question is, I guess we're all looking at some more examples of using the fewest studies.
Yeah, for sure. I think one of the things that we are pretty excited about is the idea that an investigator could come to a data repository like BioView with a particular haplotype or rare variant of interest and look at the complete spectrum of phenotypic outcomes associated with that to gain new perspective on the genomic spectrum of risk. So I'm tempted to use the word pleiotropy, but that has a really specific definition. So if you've got a gene could act in a pathway where gene affects obesity risk and then obesity risk affects type 2 diabetes risk, Or you could have a gene acting independently on multiple different phenotypes. You could have a gene that impacts obesity risk, and then independently of obesity risk, the gene could impact type 2 diabetes risk. We're going to have to do Mendelian randomization analyses and causal inference analysis in order to be able to figure out the mechanism of risk in these kinds of scenarios. But opportunities like EHR is where we're able to identify what all of those stepping stones are and then begin to figure out that causal network pathway. One particular example that I can think of, and I think this paper is likely to be coming out in Cell or Nature relatively soon, is that the head of my department, Nancy Cox, was combing through BioView like I was last night, and she identified a gene, GRIC5, and what was interesting about the gene is that it had this whole spectrum of effects on all kinds of different vascular phenotypes and eye phenotypes. And she thought, this is interesting. So she kicked it over to the zebrafish lab, and they ran CRISPR, mutated the gene, and they found eye phenotypes in the zebrafish. So it turns out that we've learned this whole new molecular pathway for retinopathy and eye development, and it all came from this discovery by looking for patterns of effect on the complete health spectrum within BioView in a very hypothesis-free kind of approach. So I think we're going to be seeing more and more stories like this come out where there's a gene whose function we don't necessarily know or what its context is, and suddenly we're able to, in big data environments, identify these patterns of effect. And so, some of the genes that I pulled up last night for some of the dental phenotypes that I was just playing around with, I think are so compelling that my lab will probably follow them up in the next coming few weeks. So hopefully next year I'll have a even more relevant to dental public health and oral health story for how fewest are affecting the field.
Great, thank you. This is for Dr. Finkelstein. Someone was intrigued by your reference to behavioral informatics technology. So three-part question. So what are the best applications in public health that you've seen? What applications are we missing? And what are the challenges to effective implementation?
The best application in public health, obviously, those applications which are grounded in behavioral frameworks. There's a variety of frameworks which were shown effective to promote health, from trans-theoretical model in smoking cessation to theory of planned behavior, to theory of reason actions, and various behavioral models which can be effectively converted into mobile health applications or interactive web-based applications. I don't have any favorite model, but obviously the applications which are driven by behavioral constructs are much more effective. It was shown repeatedly. What was the next one?
The second question was, what applications are we missing?
Well, the applications which would be more effective, this is very applications we discussed today, which would be more tailored to individual profile and would gain insight about specifics of particular individuals from these multidimensional databases. Right now, this application mostly are unidimensional, one-dimensional. They target particular feature without accounting for other features. For example, we can actually combine our knowledge of behavioral informatics with genetic and smoking cessation. So in behavioral informatics, we use different behavioral models to convey tailored messages to stop smoking. But if we know particular underlying genetics, we can understand whether particular medications, first of all, would work or not work based on pharmacogenetic. Let's say bupropion would not work with subjects with particular cytochrome polymorphism. Secondly, we can identify the risk of addiction, smoking addiction, based on genetic profile. And then combining these two inputs, at least two, we can actually generate much more powerful and specific tailored message, which probably would be much more effective. So what's missing is right now, but it will hopefully will be in the future, we can intelligently combine all this aggregated information into a tailored public health message.
Thank you. And also, great. So next question I think is also for you, Dr. Finkelstein from Dr. Slavkin. How do you evaluate social marketing versus effective and lasting health prevention benefits?
Well, social marketing was repeatedly shown as a very effective strategy, but and it's used widely in very different domains, from political science to business marketing and to social sciences. The underlying concepts are rooted in detailed analysis of populations and developing tailored messages. However, there's many other means to use technologies to convey powerful population-based messages, including behavioral informatics, including many other ways to do it, and also including interventions on providers. And actually in dentistry, one of the successful studies were done where the so-called total health interventions were done in dental clinics, where, for example, messages regarding diet and weight reduction were conveyed to patients with diabetes during routine dental visits. And actually, dental visit itself may be a very powerful teaching moment where patients can be instructed using multimedia interactive technology. In our environment, which I mentioned, which is more sophisticated, maybe unique, we can identify when patients, for example, when the waiting time allows for a patient to be approached through using some multimedia messages, we can access this patient record in real time, identify a set of dental problems, identify even medication on which this patient is, prior medical history, and then online generate in real time interactive educational curriculum which will be tailored to these patients and develop and delivered at the very time when patients is available, and educate them even prior and before the visit. So there are multiple opportunities to deliver powerful messages and public health messages using different technologies.
I think that's absolutely fascinating. The future is now. I just wanted to also throw out there, I moonlight night and weekends in my free time. I run the science forum on Reddit. I don't know if you guys are familiar with Reddit, but the our science forum there has about 18.5 million subscribed users. And I and a team of about 4 or 5 other people run that website. And it's a science communication website that is really about the dissemination of new peer-reviewed research to the general public and lay audiences. And in addition to hosting scientific content from journals and sort of media clearinghouses for scientific data, we also host something called AMAs, which stands for Ask Me Anything, where we bring in a prominent researcher in a scientific field and put them up in front of our 18 million person audience and allow them to have a two-way flow conversation, back and forth conversation. It's really one of the only formats that is amenable to this on Reddit. We've brought in some pretty incredible investigators. Francis Collins has been with us almost every year for the last couple of years. And a number of geneticists. We had Jennifer Doudna last week, who is one of the key investigators behind CRISPR. And my role on the website has been to be the liaison with the scientific community booking these AMAs. We have done about 500 a year for the past 3 years. And I just thought I would mention that I don't actually remember ever doing one with a dentist or a public health expert in dentistry. So I wonder if there's opportunities for the field here to engage a little bit more with lay audiences and utilize those and leverage those. I think marketing is one way to do it. You can put up a Facebook banner, but that's not interactive and it doesn't actually address the questions that are burning in the public mind about your field of research. Things like an AMA allow you to actually hone your message, control your message, and it creates a permanent stamp on the internet. Anybody Googling those terms, that Reddit AMA is going to come back up and get read by millions of people over time. So it's just, I figured I'd make a little pitch while I had your ear anyway.
Might as well.
Yeah.
So this question just popped up to the top is, how is precision public health different than precision health, precision medicine, precision dentistry in the public?
You're looking at me. So, well, we discussed yesterday the definitions of precision medicine, and precision medicine, it's a very, very powerful concept, which actually, to me, means delivery of medical care, which is uniquely tailored to individual profile of a particular individual. And from this perspective, the precision public health can be defined as the delivery of public health intervention, which is uniquely tailored to unique characteristics of particular subgroup of a population which can benefit from healthcare intervention, for preventative healthcare intervention. So I think that underlying technology basically is the same. Underlying technology is identifying unique characteristic of individual patient or unique cohort which can benefit for particular treatment or for particular preventative intervention. And as I mentioned in my presentation, I think that eventually even public health intervention may become interventions of N of 1. It's just a matter of scale, a matter of our ability to identify precise intervention. Actually, business marketing and these very ads we get in our emails, it's actually marketing of N of 1 because they understand your or my profile based on social footprint or other many other data which are collected, and then I get a very unique message. So the same can be done in public health arena, and the same is being done right now with precision medicine, let's say with pharmacogenetic or with genomics and etc.
Did you?
Oh, no, I think that was like
Oh, okay. Okay. So next question, and I think. Oh, okay. This is. I'm gonna take liberty and skip to one of the other questions. I think this is for Dr. Bello. And so in the genetic studies of type 2 diabetes, since this is an acquired expression over time, what impact does a major confounding factor like periodontitis have on interpreting the genetic outcomes? And does a lack of data on this type of effector of disease expression alter the genetic findings?
So correct me if I'm wrong, but I'm interpreting this to mean that we have comorbidities of traits such as periodontitis, which is seen frequently in type 2 diabetes cases, and the question is, how does the lack of data on this particular associated trait alter genetic findings? So if that's not your question, speak up. I think that it's a major knowledge gap is what it is. I mean, we're doing the work to find the genetic basis of many phenotypes, but in the absence of complete health consequence information, then we're not necessarily characterizing the full spectrum of outcomes for patients. So it's one thing for me to say that this gene influences type 2 diabetes risk. It's a much more interesting and powerful thing if I say that this influences type 2 diabetes risk and oral health, right? I think that by having the information be truly complete in the EHR, and let me say that with a really, boulder-sized grain of salt, because we're aware that EHRs are really only holding billing codes, and that these codes are not necessarily reflective of a very granular picture into individual patient health. But it's where we are today. Hopefully where we get to is that we get more bang for our buck in our genomic analyses when we have that more complete picture and the more granular picture of health outcomes. And so it's, as a geneticist, lowly sort of unidimensional geneticist in this public health landscape, my appreciation for the complexities of integrating oral health traits in EHR settings has gone from near zero understanding of those complexities to, something greater than zero, which is like infinity more. I'm so impressed with the challenges ahead for this field, and I think that it's going to be a really exciting time as this field gets over some of those hurdles. And what you have the advantage of is learning from so many of the other professions that have come so far in generating kind of the large public health databases that allow us to do the genomic medicine questions. But I think the short answer is that there's an enormous cost to not having this dimensionality in the data. We're not learning about things that we should be learning about. And I'm very excited to be meeting people that are at the forefront of beginning to think about how to integrate those traits in so that we're not missing this important slice of the picture as we're doing these studies.
And
Yes.
I totally agree. And what we know right now is that the risk of periodontal disease is strongly associated with cytokine polymorphism, and particularly for development of severe periodontal disease. And also there's ongoing interaction between diabetes and periodontal disease. And this is routine knowledge that in patients with diabetes, periodontal disease should be treated much more proactively.
Thank you. This is, I think, an interesting question. So, social media is one of the largest big data streams that is publicly available. However, as you can imagine, there are significant issues with the quality of data and generalizability. So should we still use this data, and are there effective applications in precision health?
Well, there's many ways to ensure the validity of data and the kind of sensitivity and specificity of algorithms. Anybody who works with big data understands that there's a lot of noise. And it's actually kind of initial a priori assumption. There's many ways to address this issue and still utilize advantageously this enormous data set. And I actually can claim from my experience, the larger the data, the usually, as actually was shown in the previous presentation, stronger the real signal, and kind of if you have a noisy signal, kind of cancel each other because of kind of stochastic nature of the noise. So this is why we need big data, because usually it's much easier to capture a strong signal, and if there is a noise, usually if it is not biased, then it's random and it will kind of cancel itself. With regard to social media, I think that it's being used in a very powerful way. Machine learning and artificial intelligence really using it very, very effectively. If you ever use Google Translate, it's basically machine learning, and it's actually have very good translation capabilities. Variety of other approaches which uses large corpora of textual information reached very high sophistication, and actually it's now being used in very knowledge discovery, and actually in discovery in systematizing, making systemic analysis of available knowledge of genetics. So we published some articles about data mining of PubMed and extracting information about genetic association just by natural language processing and mining underlying information. The amount of information which is constantly appears, new information, is overwhelming, and eventually we need to have technologies which, at least at first glance, analyze them automatically and try to understand them and maybe alert those who are interested. This is why I mentioned that we need so-called intelligent integrative informatics approaches. And by intelligence, I mean that with any data set, actual meaning is attached, and connection between different terms and attributes is also there, and then we can apply certain machine learning or intelligence, which at least at the first round, at first glance, can analyze it and generate hypotheses by itself. So in the example which was previously given, it's exciting when we have access to these very large databases to utilize them to check some very innovative hypotheses. And it's great that we have access to it. But right now, it depends on the very investigator who comes up with these hypotheses. Imagine the situation when computer itself would come up with hypotheses based on semantic ontology and underlying intelligence which we give them through these large linked ontologies, so that not only it can aggregate the data, but it can actually propose a hypothesis and check it itself.
Great, thank you. I was curious about this question for you, Dr. Finkelstein. Is the DDS Squared web-based course available or accessible to persons outside of the?
Yes, so this course was funded by Columbia University Data Science Institute, and this spring semester is our first time we are given it, but we plan to open it eventually to other dental schools and maybe to general public. This is basically a 3-year grant which was funded by Data Science Institute at Columbia, and Columbia, of course, is one of the leaders in precision medicine, and it has infrastructure to promote training in data science to clinicians or any other interested individuals. And at this semester, it's more trial and error, but once we identify how to deliver it in the optimal way, obviously, the plan is to make it available.
Great, thank you. We'll look out for that. So Dr. Bello, so Cora at University of Pittsburgh in GWAS studies has identified taste genes as suggestive in relation to caries. So how do those relate to the 3 putative genes found in BioView?
I don't know. Like I said, I found those last night at like midnight. I think that that's a really exciting and interesting thing for us to pursue and following up, and I'm glad somebody brought it up because now it's in my head to do. I think relating the 3 putative genes that I identified last night in our giant portal repository, I just thought it was interesting in relation to some of the other questions about how is it important to understand and not lose opportunities to understand how dental caries and periodontal disease and the genetics that underlie those phenotypes connect to other traits, that the genes that came up, all 3 of them were so significantly associated with obesity risk in the large UK biobank. And I think that is a perfect illustration of the sort of causal network that we need to be able to understand are those genes associated with obesity risk, and then because they're associated with obesity risk, we're seeing them, as then downstream being also associated with the oral health phenotypes. But I think that taste is a really exciting potential opportunity as well, and so I'll be looking up that UPitt GWAS study, in 20 minutes when I'm off the stage.
That's great. Thank you. I think we have time for maybe one or 2 more questions. So, so I think for either of you, how would? Okay. These things are popping up kind of randomly, so I had a question in mind. So I'll go with Dr. Pollack had a question. What is known about the validity of dental diagnostic data in EHRs?
Well, actually, it's a very good question. We just completed a study with one of the second-year students who got involved in our early data science program, and we found that there's a lot of gaps in documentation of dental care process, and we focused on a particular dental conditions We identify it through kind of electronic dental record widescreen, and after it was manually reviewed, actually I initially included it in my slides, but after I removed because I was kind of running out of time. But it's known that there's a gaps in any electronic health records in terms of documentations, in terms of the coding, and because electronic health record is developed to document clinical encounter and to support continuity of care. It's not research database which are done for clinical trial. We need to recognize it, but recognizing that, we need to develop approaches and methodologies which allows us still use this data in a valid way. And one of the approaches, as I mentioned before, is so-called electronic phenotyping. It's used widely now in many studies, including eMERGE consortium. It's a large multi-site consortium which merges electronic records from multiple institutions with genotyping information. And as a part of this consortium, electronic phenotyping algorithms are developed, which do not depend only on just particular disease code. It looks for so-called electronic signature of particular phenotype. As an example, I suggested was dry socket or alveolar osteitis, but there's which is frequently not coded correctly, and etc. However, it has particular signature, and the same, let's say, with implant failure or restorative procedure failure. Even if it is not coded, we can see what the temporal sequence of event is, what materials are used, what medications are prescribed, how many visits are done. And using this, even if there is some noise, we can find very specific signature, and with high specificity and sensitivity identify these events. Yes, there will be still errors, but if we deal with big data, then the specificity and sensitivity would be sufficient to produce appropriate predictions.
Thank you. And I'm going to take the lib. Oh, did you want to say something?
Oh, yeah, just as an example, I was going to throw out there that one of the phenotypes that I study is speech and language pathologies, and we study developmental stuttering risk. If somebody fills out a survey and you ask the question, did you stutter as a child and do you stutter today, they fill out those questions with like 99% accuracy to their diagnostic records. If a speech and language pathologist validates those described self-reported traits, with extraordinary sensitivity and specificity. So I assumed that when I went into the EHR that it was going to be similar. When we went into the EHR, we did like a little data mining exercise and pulled out everybody that had stutter, stammer, stuttering, developmental stuttering, or any of the phenotyping codes, billing codes for speech and language pathology related to developmental stuttering. We ended up finding out that like less than 30% of the people who had billing codes for stuttering actually stutter. Is because the physicians didn't have the ability to find the right, or the time to find the right code for billing code if a child came in with a traumatic brain injury and had concomitant stuttering of speech. Same thing with neurogenic and psychogenic forms. Anyway, it was a big wake-up call to me personally, as like, oh my gosh, something that even can be self-reported with such high accuracy is not being reported accurately in the EHR. That was like an important thing. But what we've done now is use some machine learning algorithms and plus the hand-curated data with speech and language pathologists to be able to identify, like you said, the signatures in the EHR that you find that validate that, yes, this is a case of developmental stuttering, or no, it's not. So for example, a lot of the false hits were heart stutters or heart stammers. So now we can hone in our aggregation towards that phenotyping to get improved more and more and more. I think there'll be a lot of opportunities for things like that as we move forward, but I just wanted to give you guys the one example.
That's incredible. You would have thought otherwise, right? So we are at 10:30. There were a lot of other questions on Slido. I'm sorry we didn't get a chance to get through all of them, but there's an opportunity to ask questions in the next half hour and maybe later on after the program ends today. Dr. Finkelstein, Dr. Bello, any of our other speakers. Please help me thank them again for their wonderful presentations. And thank you both. So now we'll take a 30-minute break. There's some refreshments back in the same